The authors, their immediate family, and any research foundation with which they are affiliated did not receive any financial payments or other benefits from any commercial entity related to the subject of this article. This manuscript has been read and approved by all authors. Each author believes that the manuscript represents honest work. Meniscal tear is a commonly encountered clinical entity for the practicing orthopedic surgeon, with an incidence as high as 6 per 1,000 people. Arthroscopic treatments of meniscal injuries are among the most commonly performed orthopedic procedures, constituting 10 to 20% of all surgeries at some centers. While optimal visualization is crucial for the diagnosis and treatment of meniscal pathologies, access to the posterior horn of the medial meniscus might be challenging in patients with a tight medial compartment. We describe our experience with an arthroscopic inside-out selective deep MCL pie-crusting release technique that allows for good visualization of the posterior horn of the medial meniscus in patients with a tight medial compartment. While the junction of the body and posterior horn of the medial meniscus is visualized with a 30-degree arthroscope through the anterolateral portal, an 18-gauge needle is inserted through the anteromedial portal, and a gentle valgus force is applied. Multiple needle punctures of the deep MCL are performed under direct visualization, starting at the posteriormost part of the ligament just proximal to the menisco-synovial junction. Puncturing to sever the deep MCL fibers is then extended anteriorly while applying a gentle valgus strain to the knee, until adequate visualization of the entire posterior horn of the medial meniscus is achieved. At this stage, dedicated instruments are easily inserted into the joint, and the pathologies of the meniscus are addressed while minimizing iatrogenic chondral damage to the knee. This is a right knee viewing from the standard anterolateral portal. A tight medial joint space limits the view of the posterior horn of the medial meniscus, as well as the advancement of a duckbill punch to reach the posterior horn without injuring the articular surfaces. With an 18-gauge spinal needle inserted through the anteromedial portal, multiple punctures of the deep MCL are made at the junction of the posterior horn and the body of the medial meniscus. This is performed under gentle valgus stress applied to the knee and frequent assessment of the medial joint space opening until adequate space is achieved. A partial meniscectomy is carried out safely without scuffing the articular surfaces. Removal of the meniscal debris is facilitated through a cannula, in this case, the external sleeve of a helicutter shaver.